Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hassaballa.
Hello, everybody. Great to have you here. I'm glad to be back. So, there's a couple of things I wanted to speak about: litigation and documentation, because I think it's important, especially as the residents are leaving residency, residents coming in residency. I was also requested to talk about neurologic emergencies in the ICU, especially at night, and so we can begin to touch about that neurologic ICU, because it's like it's interesting. The management, depending on the cause of the stroke, for example, if we talk about stroke, they are diametrically opposed management, right? And so you really have to know the difference between what you're dealing with when it comes to acute stroke. And this is like fresh in my mind because I just recertified emergency neurological life support. So it's all fresh in my head about neurological emergencies and stuff like that. So we can talk about acute stroke, ischemic, and hemorrhagic, because the management is different, and you kind of have to know what you're dealing with, right? And then we can kind of touch on hypertensive emergency, and then we can field some questions if there's anything else you want clarified, and then I do want to get into documentation and litigation, just as kind of a my final parting gift to the residents who are graduating and either becoming fellows or becoming attendings. When it's for real this time, you can't hide behind your attending. You become the attending, and the buck stops with you. So acute ischemic stroke, right? You come in, someone has a new onset facial droop, one-sided weakness, dysarthria, the mental status change. You do the workup, you get an acute CT scan, or you call a code stroke, you get an acute CT scan, there's no evidence of bleeding. Well, why are we getting acute CT scan in somebody with an acute stroke? And why? Okay, so before we even do that, what is the first thing we need to know when someone presents with suspected stroke? First thing we need to know. Last known well. Absolutely. You have to know with a great degree of certainty when they were last seen as well. Is it 5 a.m. this morning, or was it 8 p.m. last night? Big difference, because there are treatment windows. You can't just give TNK to anyone at any time. There has to be within, now I think it's 4.5 hours, right? Before it used to be 3 hours, and then they did randomized trials that show you can extend it to 4.5 hours. But it's 4.5 hours from last known well. It's not 4.5 hours when they woke up. It's big difference, because if you give TNK now, thankfully, people have gotten TNK for not acute strokes, and they've done okay. And there are times where you have devastating neurologic hemorrhagic complications of TNK. They can be devastating. And so you really need to know when they were known well before you embark on the possible administration of TNK, the thrombolytic therapy. So last known well, exactly. So then you've established the last known well. Say it's 2 hours ago. They were last seen well at 5 a.m. They present at 7 a.m. You get the CAT scan of the brain. Why are we getting a CAT scan of the brain? Yeah, exactly. Do you want to establish, is this an ischemic stroke or is it a hemorrhagic stroke? If it's an hemorrhagic stroke, I really hope no one in this room or in Sussex or in the clinic or online would ever give a thrombolytic to somebody with a hemorrhagic stroke. I really hope that would never happen. And there are, few nevers in medicine. That's one of them. Never give a thrombolytic to someone who's bleeding. It's as simple as that, right? Never do that, please. So, yeah, you have to establish, is this a hemorrhagic stroke or is this an ischemic stroke? So the CT is negative. There's no evidence of hemorrhage, right? Then you've engaged the stroke specialist, right? I personally, even as an intensivist, I get them after as an intensivist. At the same time, if I was faced with that, I would definitely want to consult with a neurology specialist, someone who is an expert in the field, to make sure, and then you get informed consent. That kind of segues into documentation and litigation. You got to get informed consent from the family and the patient. Listen, this is potential benefit, but there are significant potential harms with TNK that can be devastating. Eyes wide open before you just say, "Oh, I think we should give you this medication." And you have to explain to them the risks of this. Is a very high risk medication. It's a very high risk medication. And then you administer TNK. Now, what's the primary difference in management post admission to the intensive care unit, for example, with an acute ischemic stroke versus a hemorrhagic stroke? What am I doing differently? Blood pressure management, exactly. With an ischemic stroke, you're much more laissez-faire when it comes to blood pressure management. Why? Why do we let the blood pressure go up a lot higher than many people are comfortable with? Perfusion, exactly. Because when you have an area of ischemia in the brain, what happens to the area around the ischemia? What was that? Why is it not perfusing? How come? Because there's edema, right? When you injure tissue, what happens to the tissue? It swells. Brain is no different, right? When you have an area of ischemia, you have the surrounding area that's at vulnerable because of tissue edema. So now, if you're very aggressive with blood pressure control, you can compromise perfusion to the what we call the ischemic penumbra, the area around the actual ischemic tissue, and you can extend the stroke further and make the area of damage more extensive. So, what is the blood pressure target after you give administration? Or now TNK is a little different. So there's two. So you give TNK. What are we keeping the blood pressure at? That's way too low. 140 over 90 is way too low after TNK. 185 over 105. That's it. Sometimes they come in with 220 over 140, right? When they come in, but 180. Once you give them TNK, all you got to do is keep the blood pressure below 185 over 105. Okay, 140 over 90 is way too low. And if you don't give TNK, say the last known well was 8 p.m. last night, they present at 6 a.m. in the morning. That's well beyond. Now we're not talking about neurointervention. We're just talking about TNK. Neurointervention is 24 hours. You have 24 hours to potentially intervene to do a thrombectomy or maybe intraarterial thrombolysis. But that's why we get CT angiograms to see if there are acute occlusions that we can see, and if they were within 24 hours, they're potentially can be candidates for neurointervention. Okay, but 185 over 105. Now, if you don't give TNK, 180, 185 over 105. Mm-hmm. Usually it's 185 over 105, if I'm not mistaken. I'll double check that. Prior to, after, it might be 180 or 105. Yeah, it's very very similar, and you don't want to be too much because again, when you're too low, you can compromise the ischemic penumbra. The other now, if you don't give TNK and they're not a candidate for neurointervention, now you let the blood pressure can go up even higher. Even into the 200s, because again, you don't want to compromise perfusion to the surrounding area of swelling. Okay, if you have a hemorrhagic stroke, it's the other way around. You don't want them to be hypertensive. Right? You want now, depending on the situation, sometimes we will target a systolic blood pressure of 140. Other times, I've been told to by the neurosurgery to target a systolic blood pressure of 160. So between 140, depending on the situation. If they're chronically hypertensive, sometimes you don't want to be too aggressive with 140. You may want to just get it below 160. Because again, if you're too hypertensive and you have a bleed, you're only going to extend the bleed and make it worse. Because most of the time, intraparenchymal hemorrhages are hypertensive related. Most of the time, right? Remember the little perforators that come out of the main arteries that perforate the little areas of the brain, especially the basal ganglia? Those little side branches can't take high pressure for too long, and they just burst. And then you have an intracranial hemorrhage. This is different than subdural hematoma, subarachnoid hematoma, and not subarachnoid hematoma. If it's an aneurysm rupture, that's a different story, right? you also want to control blood pressure, right? But we're talking about intraparenchymal hemorrhages that are hypertensive related. You want to definitely aggressively treat the blood pressure, but depending on the chronicity of the hypertension, you got to be careful. You don't want to go to systolic of 80 or a systolic of 100. You don't want to do that, because that, again, can, in somebody whose brain parenchyma, whose brain vasculature is used to a mean arterial pressure of 160, and then you decrease it to 80, that can potentially cause them to stroke out. Think about it, right? There you have, remember the curve of the autoregulation curve, cerebral vascular autoregulation, that the brain vasculature keeps perfusion constant over a wide range of blood pressures. Once you go above the certain threshold, the more arterial pressure you have, the higher the perfusion. But over time, chronically untreated hypertension, if you have the vasculature remodels to accommodate a mean arterial blood pressure of 160 all the time. So now they come in for hypertensive emergency, for example, and what's the difference between urgency and emergency? And organ damage, exactly. So hypertensive emergency, you'll have heart failure, ischemia, renal failure, mental status change, those kind of things. If you have evidence of end organ damage, then you only reduce it by 10 to 20% in the first hour or so, and then by no more than 25% mean arterial pressure by the first day. Why? Because if you go from 220, or I had just last week, I was working clinical, I had a lady come in with 270 was her systolic, and her mean was 210. I mean, if I go to mean of 60, she'll have a stroke. 100%, or it's just potential. I don't want to do that. That's me. That's me doing. So I only targeted her mean arterial pressure to go down to 160. Mean, not systolic. The nurses were like, "You mean systolic, right?" I go, "No, I say mean, the mean arterial pressure." So she's riding with 180 systolic all the time, and that's totally fine. She felt crummy, but at least she was moving her arms and legs and not having a facial droop and slurred speech and aphasia. That's iatrogenic. That's me. That's not her. That's me. So we have to know what we're doing. And so again, you have diametrically opposed managements. You got to know what you're dealing with when you're dealing with a neuro emergency coming into the ICU. You have to know, is this a ischemic stroke? Is this a hemorrhagic stroke? Is this subdural hematoma, which also there is blood pressure control? You don't want to have really high systemic pressures when you have a subdural hematoma. A subarachnoid hematoma, is it an aneurysm rupture? You also want to control blood pressure. Epidural hematoma, remember the classic, and I've seen it happen. They lose consciousness, they wake up, they look totally fine, and then they crump. That happened to me. Happens, and you gotta intervene and know what to do. Right? If you have an acute mental status change in the ICU at night, have a low threshold to image the brain. I don't know what's going on. Especially if they cannot tell themselves, right? If they can't say, "Oh my God, I can't now. My left arm is numb where it wasn't before." And if they're obtunded, and then there's a new change, to have a low threshold to scan the brain. Someone's on anticoagulation, and all of a sudden they suffer mental status change. They could be bleeding in the brain. I had a case of a patient post-op cabbage, was tubed for a long time. We can't do a thorough neuro assessment. Several days later, we get a CAT scan. There's a big brain bleed. It's too late then, right? Which is why we do what on intubated patients every day? You don't count. What? Spontaneous awakening trials. Right, exactly. That's why we do SATs every day on intubated patients. When I do an SAT, that does not mean I'm planning to extubate the patient. Okay? If they are on 12 of PEEP and 100% FiO2, okay, with pressure control, they're not. I'm not going to extubate that patient, okay? And I want to make sure that they are moving their arms and legs, that they didn't suffer a stroke. One of my first patients in practice at my current place was a lady with ARDS, and we didn't do SATs every day. And when we finally did one, she wasn't moving. She wasn't doing anything. And I got blood, and I got a CT scan, big brain bleed. It was too late, and she passed away. Those cases stay with you. That stays with me. Listen, this was maybe 12 years ago, 11 years ago. I still remember. Young. She was in her 30s. Got to do a spontaneous awakening trial every day. You got to see, and then you reduce the sedation to the lowest effective. Now, when is the one time you won't do a spontaneous awakening trial? Which would be torture and cruel. If they're paralyzed. Exactly. If you have a bad ARDS and you have neuromuscular blockade for 48 hours, which is what is recommended when you do it, please don't wake them up. Don't do that. How would you like to be awake and you can't move any of your muscles? That would be torture. So don't do that. When you're paralyzed somebody because they're really bad ARDS, you forego the spontaneous awakening trial, but only through the duration of paralysis. And you should only do paralysis for about 48 hours. And then you stop the paralysis and you wake and you stop the sedation. And I'm talking about when it's a spontaneous awakening trial, it is a spontaneous awakening trial. You stop sedation, you interrupt sedation and analgesia, and you wake them up and you see what happens. Do they follow commands? Do they don't follow commands? Now, if there's still a RASS of -5, completely unresponsive, why are you going to put sedation back on? Why? And if you stop sedation and there's still a RASS of -5, and maybe it's because of prolonged action of the sedatives and stuff, but if it's not, maybe something's happened and you need to image the brain if it could be done safely, right? So that's why it's very important. In the past, we just put them on ventilators, just let them sit for days and days and days on midazolam drips or lorazepam drips and whatever. And then finally, when we decide, well, maybe we'll wake them up now, we stop the lorazepam, and now all the lorazepam that was in the lipid tissue is coming out and continuing. So there's another pump of lorazepam that keeps them asleep for another 4 or 5 days. But surprise, surprise, people will be on ventilators for 2 weeks. I think, we have to trick them. That's not how it's done. That's not how it's done. Every day we interrupt sedation to see. And if we can get away with lower sedation, we do. And that's shown in, it's old stuff, guys. This is like, I don't even know if it's even in the 21st century research. I can't remember exactly when the daily interruption trials were in the University of Chicago, but they showed that people got off the ventilator faster, which is exactly what we want them to do. We were trying to liberate them from mechanical ventilation as fast as possible. As fast as possible, get them off of the ventilator. And that's why we don't almost never use benzodiazepines. Well, I don't say never. I hate benzodiazepines. I can't stand them. I almost never use them unless someone's seizing, or maybe cocaine toxicity, or alcohol withdrawal, something where benzodiazepines are indicated. But but continuous sedation, it's just not what you do. I don't care about the blood pressure. Remember rule number 1, 2, 3, 4, 5 of the ICU is what? What's rule number 1, 2, 3, 4, 5 in the ICU? No. Don't panic. Don't panic is rule number 1, 2, 3, 4, 5 in the ICU. So you have somebody comes in, gets intubated for whatever reason, hemorrhagic stroke, okay? And they're on clofidipine, all right? You're trying to keep the blood pressure at 140. Okay, and their blood and then no, that's a bad example. Let me go septic shock, and they get and they get intubated, right? And you want to sedate them, and they start propofol, and the blood pressure goes down from 80 goes down to 65. Oh my God! So we stop and put them on Versa drip. Wrong. If I'm the attending, I'll be very mad. So what if their blood pressure goes down? That's why I have norepinephrine. Who cares? Don't panic. Nothing's going to happen. Treat the blood pressure. It's better to put someone on propofol and fentanyl and have them a little bit hypotensive, well, I can treat, that I can deal with and treat, rather than put someone on benzodiazepine, which causes people to be on the ventilator longer, gives them delirium, which is life-threatening, and keeps them on the ventilator and just messes everything up. Don't do it. Benzos have their indication, and continuous sedation for mechanical ventilation is not one of them. Even if they're in status epilepticus. Even if they're in status epilepticus, propofol is an anti-seizure medication. Phenobarb is an anti-seizure medication. Pentothal is an anti-seizure medication. Even then, maybe, if I know someone who's documented has status epilepticus, maybe I'll do benzodiazepine. Maybe. But propofol is just as good. It's a general anesthetic. Which is another thing. If someone's not waking up, we shouldn't forget about seizures. Because not all seizures convulse. And sometimes you may have non-convulsive status. And if somebody's seizing for days and days, that's damage to the brain. You guys are lucky that you have continuous EEG here, or you can get it. I can't, where I'm at. So it's very difficult. And to get an EEG, sometimes it's pulling teeth. To get an EEG right now. Yeah. So you're lucky that you can do that quickly and can diagnose. Are they seizing or not? Do I know or not? That way you just eliminate that out of the picture. So don't forget about seizure. Because that's especially someone who has subarachnoid, right? We put them on anticonvulsants to prophylax them against seizure because they can. And sometimes they don't convulse. And then you won't know. All right, I'm going to stop there. Questions? Anything about neurological issues in the ICU at night? Daily. Once a day. Yeah, I guess if you do it twice daily, yeah. I mean, maybe it's just not working that day. But usually daily. I've done it daily for years, and it's been fine. If they're not ready, they're super agitated, but again, if you're not going to extubate them because they're just too hypoxic, or they're septic shock and they're on 35 of norepinephrine and 0.04 of vaso, you're not going to extubate that person, right? They're too hemodynamically unstable. So extubation is off the table. But at least I do a spontaneous wake just to make sure they're moving, everything like that, and then just let them rest, right? I don't necessarily think you have to do it twice a day. I usually don't do it twice a day. That doesn't mean that I'm the be-all, end-all. I'm just saying I just want to do it at least once to know that they didn't stroke out, and I can't tell. You know what I mean? But that's a good question. Anything else about neurology? Yeah.
Your thoughts on the slow
So the question is, what are your thoughts about this slow spontaneous awakening trial that takes all day? That is not a spontaneous awakening trial. That is the same thing as a cup of coffee bolus, where you give 250 cc's, which is this, over 1 hour, which is exactly what I'm doing here. I'm going, I love my French vanilla coffee. And then I just sit there. That is 250 cc bolus over 1 hour. That's not a bolus. A bolus is where you squeeze the blood in, or you literally squeeze the fluid in. That's a bolus. Okay? Like you're eating. That's a food bolus. You may take it over a little bit to savor it, but it's a big thing all at once. All right? That's not a spontaneous awakening trial. That is I don't know what that is. Spontaneous awakening trial, the study was daily interruption of sedation. They just stop it. Again, why don't they want to do that? Because of panic, clinician panic. They're worried about what might happen. Yeah, that's why we're doing it. Could they self-extubate? Yeah, They might. And somebody with a PEEP at 25, it's kind of scary if you self-extubate, right? But it's daily interruption. You stop it completely. It'll be okay. Nothing's going to happen. You just stop the sedation. You tell them a spontaneous awakening trial is stop the propofol and stop the fentanyl or the morphine or the remifentanil, whatever, and see what happens. And we let them wake up. But they might become agitated. Mm-hmm. But they might become tachycardic. Mm-hmm. But they might become tachypnic. Mm-hmm. Yep, I know. Keep going. That's what a spontaneous awakening trial is. It's not going from 65 to 60 to 50. That's not that's I don't know what that is. You should be doing that anyway. You should be titrating propofol based on RAS anyway. They should not sit unless they're paralyzed, where we on purpose put them at a RAS of -4, -5. They should not be at a RAS of -4, -5. They should be at a RAS of 0 to -1, 0 to -2, all the time. So why are you going, gingerly like that? That's not a spontaneous awakening trial. So you just, gently direct your colleague to say, stop it, please. Stop the fentanyl, stop the propofol. And it's okay. I'm here. That's why we're in the ICU, and that's why they put us in the ICU, and we sit in the ICU all day, because we are watching for things to happen, because things can happen unexpectedly all the time. One of my other rules in the ICU, the only predictable thing of the ICU is that it's unpredictable. Someone could be doing great, everything's fine, and then all of a sudden they're not fine, and you have to deal with it. And then you go back to rules 1, 2, 3, 4, 5 is you don't panic when something bad happens. The other thing, I could be sitting. Last Sunday I was working, everything was going great. I was bored. I was walking around. I couldn't wait till the shift be over. Right, 15 minutes before shift is over, someone comes in, starts crumping, and there I am. I leave 2 hours later. That's the way it goes. That's the way it goes. That's how it happens. That's the only predictable thing, is that it's unpredictable. So, but that's why we're there in the ICU all day, to watch for things that can happen. And when you stop sedation, they might become agitated and tachypnic and tachycardic. You just have to protect them from themselves and make sure that if self-extubation could cause them to die, you make sure they don't self-extubate. You keep them safe. That doesn't mean I'm going to keep somebody on an RAS of -5, which is comatose, just because it makes your life easier. That's not appropriate. That's just not appropriate. That's a great question. That's not a spontaneous awakening trial. I don't know what to call that. It's not a spontaneous awakening trial. No. You have to come up with a cool name. The cup of coffee bolus. The reverse cup of coffee bolus. Now you can see that's another thing. Well, they got 250 cc's. Oh, you mean a cup of coffee? Oh, okay. Over an hour? Oh, all right. Thank you for listening. To get every episode delivered directly to your inbox, please subscribe at healthcaremusings.com.